So very interestingly, the only, I would say, approved treatment so far is still hormone therapy in general, under the form of intermittent androgen deprivation therapy. This is a study conducted by the Canadian 15 years ago that showed that intermittent androgen deprivation therapy do as well as continuous androgen deprivation therapy. There is a caveat, though, is that we have never defined what is the optimal time to start hormone therapy. What we know, and once again it points at the same thing, is that there is no benefit probably of hormone therapy if your Gleason score was low and if your PSA doubling time is long. So I mean that we can take as a preliminary point to say that hormone therapy is the standard of care if you have a high risk PSA recurrence, meaning high Gleason and or rapid PSA doubling time. Starting from this, what you can do is image the patient and discuss stereotactic radiation therapy if the patient has a few metastases. Whether it should be used to delay hormone therapy or to increase the duration of the intermittent androgen deprivation therapy is still to be discussed. But what is very important nowadays is the result of EMBARK, meaning showing that once you have decided that hormone therapy is indicated, it is much better to use a combination of androgen deprivation therapy and enzalutamide. And I say enzalutamide at this point in time because it's probably going to be the same for all the other hormones. And what is very interesting is that it also raised the question, do you need androgen deprivation therapy? Could you use enzalutamide monotherapy? So clearly, the reference treatment for a high-risk PSA recurrence is hormone therapy. When you should start it effectively still can be a little bit fine-tuned. Once you start it, it has to be intermittent. And I believe there's a great opportunity for metastatic hormone therapy to increase the duration of intermittence. And what we know for now is that it has to include an AR pathway inhibitor, enzalutamide at the present time. And we're going to have to discuss whether you give ADT or not. That would be a summary on the systemic treatment.